All right, everyone. I'd like to welcome everyone to tonight's version of Neela Nights. And tonight, it's my pleasure to have Dr. Paul Richter joining us. Dr. Richter serves as the Eugene Brunwald Professor of Medicine at the Harvard Medical School and is the director of the Center for Cardiovascular Disease and Prevention at the Brigham and Women's Hospital in Boston. Over 30 years, Paul and his collaborators have provided the first proof of principle of inflammation causing atherothrombosis in humans, the first demonstration that statin therapy is both a lipid-lowering and anti-inflammatory therapy, the first FDA-approved diagnostic test for vascular inflammation, looking at high-sensitivity C-reactive protein, the first proven anti-inflammatory treatment for heart disease using canakinumab, and brought into clinical practice the worldwide concept of a residual inflammatory risk. On multiple occasions, Dr. Richter's work has altered clinical guidelines for the diagnosis, treatment, and prevention of atherosclerosis, the most common cause of death in the planet. Dr. Richter is also known internationally, having led various clinical trials, including the Jupiter trial, Prevent trial, Spire 1, Spire 2, Cantos trial, CRIT, Prominent trial, Zeus trial. Dr. Richter is a recipient of multiple honorary degrees and international awards. He is a distinguished scientist of the American Heart Association and elected member of the National Academy of Science. Dr. Richter serves, as I said, as the director of the Center for Cardiovascular Disease Prevention. Tonight, he's going to speak on inflammation and atherosclerosis. Where have we been and where are we going to? And it's my pleasure to present.
Heart disease, so maybe it can help people be healthy.
Can we just mute our microphones, everybody?
Kellen's going to be so happy to see you, and then you can play your.
Can everybody please mute their microphones, please, so I can formally introduce Dr. Richter and his talk tonight on inflammation. So with that, it's my pleasure to present my friend, Dr. Paul Richter, who's going to speak on inflammation and atherosclerosis. Thank you, Paul. Appreciate it.
Well, Guy, thank you very much. I'm going to ask you a small favor, which is, since we're doing this on Zoom, if something happens here, just pipe back in and let me know that we locked up or something like that. It's my absolute pleasure to join the Northeast Lipid Association group this evening. My hello to lots of friends at Northwell. Guy told me that some are calling in from elsewhere, so that's great. I told Guy I might be a little provocative this evening, keep you sort of thinking about things. And so this title, Inflammation and Atherosclerosis, was picked for a reason. Where have we been? Where are we going? But also because I think that in the lipid lowering world, and I certainly am a card-carrying member of that part of preventive cardiology, I actually think that we need to probably move past that alone and think about targeting inflammation directly. And I will talk a little bit about what we can do today. I'm going to talk a little about colchicine, actually, because that might be kind of fun. I have all kinds of conflicts of interest, so take it with a grain of salt, which is probably appropriate in any sense. I want to start in 2016 for a very specific reason. I wrote this commentary for the European Heart Journal. It was entitled Residual Inflammatory Risk. That was the first time this term ever appeared in the literature. Addressing the obverse, or the backside of the atherosclerosis prevention coin. And the reason we did this is because my atherosclerosis clinic, very similar to Guy's and presumably yours, is filled with people who have known cardiovascular disease. In this particular case, I picked someone who had an elevated LDL cholesterol and an elevated high sensitivity CRP, because that's extremely common to have both problems. You can't get out of my clinic not being on a high intensity statin. And we've talked for years about the left-hand side of this, residual cholesterol risk, which in this example, I just simply said, okay, the LDL came down from 150 down to 100. That's not enough. And so in 2016, we said, well, maybe you'd want to give some adjunctive LDL lowering. By the way, in 2016, just for historic purposes, the only data we had was for ezetimibe, which, as you may know, was a very small 7% risk reduction. So that's all we had in 2016 on top of a statin. But anyway, in this commentary, I also said, look, there's the other side of the coin, which is residual inflammatory risk. In this instance, with the high intensity statin, the LDL is nicely down, 65 or 70 or so, but the CRP is still greater than 2 milligrams per liter, in this case, 3.8. And I made the argument that we really need to think about residual inflammatory risk and maybe treat that. But of course, in 2016, we had no evidence of any of that. Well, in 2023, we know that lower is better is not just true for LDL. It's also true for inflammation inhibition. And that's the challenge I sort of want to throw out to you this evening. So let me tell you how we got into this recently. And this is probably the provocative part of this to make people think about what we're doing tonight. I'm going to argue that we should be thinking about whether the time has come to chart a very new course in secondary prevention. We can come back to primary prevention later if we want to, but in secondary prevention, should we be thinking about atherosclerotic disease differently? And the only way to really get there is to answer two fundamental questions. The first is, what's the relative importance of inflammation and cholesterol as determinants of residual risk after you've put a patient on high intensity statins, which is most of our clinic? And secondly, what are the anticipated benefits of adjunctive lipid lowering as compared to adjunctive inflammation inhibition after the initiation of high intensity statins? So the idea here is, what are we going to do as our second drug, if you like, once you put someone on a statin? So we went about this in a very interesting way. Many of you know that my research group had run the clinical trial that you know is prominent. This was the 10,000 patient trial of pemafibrate that did not show event reduction. I had that data in my hands, and I decided to look at whether or not residual inflammatory risk and residual cholesterol risk predicted outcomes. I got some very surprising data back, surprising even to myself. And so I thought, okay, I'm not going to publish that until I have some external validation. So I called up Deepak Bhatt and said, hey, can I do the same analysis and reduce it? I called up Steve Nissen and said, hey, can I do the same analysis and strength? The three academic folks, not surprisingly, agreed. We got the companies to agree. And I'm going to show you the data that we just published in the Lancet a couple of weeks ago that were presented at the ACC to get you to think about this. So ultimately here, we're talking about over 31,245 statin-treated patients in prominent reduce it in strength. And again, the point here is these were not trials of CRP or LDL lowering drugs. The first thing I want to show you is on this slide. The quartile cut points for HS-CRP, which is the top half, and the quartile cut points for LDL cholesterol in the bottom half are virtually identical in these three major clinical trials run on a global basis. That's very important for you to know, because people say, oh, you know, CRP is highly variable. It's not. The variability is no different than LDL. So the median CRP is here about 2.2, and the median LDL is around 75, and they line up identically in the three trials. So this is the first thing I want you to think about. We asked the question, what predicts cardiovascular death in these 31,245 patients already treated with statins, and about 2/3 of them with high intensity statins? What you see on the left are three stacked bar graphs. The top one is the data I generated on my own in Prominent that I didn't want to publish until I had some confirmation, because I was surprised to see that the high sensitivity CRP, increasing quartiles of HS-CRP, was a very strong predictor of cardiovascular death. You see that in the black bars. But the white bars, LDL cholesterol, was a predictor, but it was much smaller in its utility. And I said to myself, okay, Paul, don't publish that until you have some confirmation. Well, you see the reduce it data below that, you see the strength data below that. It's absolutely true in all three studies. So that on the right-hand side, you see the pooled data that the increasing quartiles of high sensitivity CRP, which many of you probably are not measuring, has a hazard ratio almost 3, whereas LDL cholesterol, which I'm sure you all measure, has a hazard ratio of 1.27. Further, if you look at this in tabular form, the risks associated with HS-CRP of a recurrent cardiovascular event, in this case, cardiovascular death, really climbed quite dramatically. And all data is highly statistically significant. On the bottom half, in contrast, LDL cholesterol was really not a particularly powerful predictor of residual risk at all. The top quartile was statistically significant, but the second and third were not. And this brings into question the whole idea of, well, after we've put a patient on statins, what's our real problem? Is our problem further LDL reduction. And now clearly we have lots of clinical trials that show us that the relative risk comes down with second agents like PCSK9 inhibitors as an example. But as we all are aware, the cost is exploding, and the relative reduction one gets is getting, the absolute reduction one gets is smaller and smaller. Okay, well, we kept on looking at these data, and this is all-cause mortality. And it's a very similar story again and again. My patients, like yours, are mostly concerned about surviving. But once again, residual inflammatory risk, a much more powerful predictor of all-cause mortality. And again, same pattern. You see the data in tabular form here. Hazard ratios for residual inflammatory risk, which again, many of you probably don't measure. 1.0, 1.3, 1.6, 2.4, all highly significant. And residual cholesterol risk, again, not much going on at all until you get to the very highest levels, which was moderately statistically significant. Now, I want to really push this envelope a little bit further. We divided these cohorts up on an a priori basis on the canonical thresholds of hsCRP less than or greater than 2 milligrams per liter, and on the standard ACC-HA cut points of LDL cholesterol less than or greater than 70. So on the far left is a lowest risk group. That makes sense to me. They have low CRP and low LDL. That's fine. On the far right-hand side, the highest risk group that has a high CRP and a high LDL. That's also fine. But in between challenges many of the things that we practice every day. Because the group second in from the left, when the CRP is low, but the LDL was above 70, there's almost no risk. But second in from the right, when the CRP is elevated and the LDL is already below 70, the risk is very high. So the question here becomes, why aren't you measuring CRP? And should we be targeting inflammation instead of targeting LDL itself after being on a statin? So now we were at the ACC, we're extremely careful. So this is what we actually said. These are my slides from the ACC meeting. Among contemporary statin-treated patients, residual inflammatory risk as assessed by hsCRP is a stronger determinant of the risk of future cardiovascular events, cardiovascular death, all-cause mortality, than residual cholesterol risk as assessed by LDL. And in all three of these big contemporary trials, prominent strength reduce it, statin-treated individuals with elevated CRP were at high cardiovascular risk, irrespective of the on-treatment LDL level. But we also said, while these data must not be construed to diminish the proven and crucial role of adjunctive lipid lowering for those with persistent or refractory hypercholesterolemia, they do suggest that targeting of LDL alone is unlikely to completely reduce atherosclerotic risk, and that inflammatory pathways have yet to be fully exploited to reduce fatal and non-fatal cardiovascular events. And so the challenge I throw out to you tonight, as we did at the ACC, is following statin therapy, should we as clinicians elect to use a second lipid lowering agent, or should we choose instead to use an anti-inflammatory agent? So I show you here a slide I did not show at the ACC, but it's something I really want you to think about. Over the last 10, 15 years, these are basically the large-scale outcome trials of lipid lowering and inflammation inhibition that we have. So I mentioned in that 2016 monograph I opened with, the only data we had back then was from Improve It, pretty small 6% relative risk reduction for adding ezetimibe to statin therapy. Then you see Fourier, Spire 2, and Odyssey. So that's evolocumab, bococizumab, alirocumab. This is all the PCSK9 trials, a remarkably similar 15, 16% relative risk reduction on top of statin. You see Cantos, which of course was the IL-1 beta inhibitor. That's our data, which is a 15, 16, 17% reduction, very similar to the PCSK9 inhibitors. And then on the far right, you see the two colchicine trials, Colcott and Lidoco 2, which actually have larger relative risk reductions, and substantially larger absolute risk reductions than any of the drugs on the left. Colchicine obviously is a generic, inexpensive agent. And so one of the challenges for us is, why are we not using it? Now, I do have an asterisk on there. I would not give colchicine to patients with chronic kidney disease. I'll come back to why in a little minutes, but I just want you to think about that. But I also want to end my little opening piece here by saying, look, it's not an either or situation. In the future, my colleagues and I strongly believe that combined use of aggressive LDL lowering and aggressive inflammation inhibition is going to be standard of care. The question is, how do we get there, and how do we as physicians deal with the challenge between what's best for our patients and, frankly, the way we get marketed by large pharmaceutical entities. So with that general introduction, let's go over how we got here. You see Russell Ross on the left, Ron Hansen in the middle, Peter Liddy on the right. I picked these simply because these are sort of the three canonical review articles in the New England Journal to appear between 1999 and 2013. And as the inflammation hypothesis of atherosclerosis sort of developed from a pathologic perspective, which is Russell Ross's, to a adaptive and an innate immunity perspective from Peter and Garan. But I'm obviously a clinical investigator, and we've looked at this from a very different perspective, which is saying what really works. And so, as most of you, many of you are probably aware, my research group has now for 30 years asked a single question: can targeted anti-cytokine therapy reduce cardiovascular events and prolong life? The patient, the aorta on the far left is obviously severe descending atherosclerosis. The hands are from a patient with rheumatoid arthritis. And I make that comparison on purpose because at the end of the day, many of these defects of innate immune function are similar. And we're trying to figure out why one affects the joints, why one affects the vascular system. The right-hand side is a cartoon of the NLRP3 inflammasome cascade. It's within that inflammasome that pro-IL-118 and pro-IL-1 beta are activated. They're both locally secreted. IL-1 beta has a number of direct vascular effects, including upregulating the central signaling cytokine IL-6. IL-6 in turn upregulates production of the biomarker that you use, high sensitivity CRP coming out of the liver. And we have a number of targets that I'm going to go over very briefly to convince you that we really ought to be hitting this system very hard, along with lowering LDL cholesterol. So for me, this story begins in 1997. I was working for Charlie Hennekins, who many of you remember is the person who put aspirin on the map. This is the Physician's Health Study. And we showed way back then that what we now call high sensitivity CRP, we had to plate these assays ourselves back in the 1990s, was a strong predictor of future vascular events. That's the data in the lower left. And it was very persistent over long periods of time. This was actually a crucial paper because this is the first time anyone had shown that inflammation precedes by years the onset of acute coronary ischemia. Up until that point in time, people had thought that inflammation was a result of ischemia. This flips the entire cascade on its head. And we're very lucky because this was done in the context of a randomized trial of aspirin, the anti-inflammatory drug. And so you see in the white bars in the lower left that this whole effect was attenuated by this anti-inflammatory drug. And so for the next 27 years, this is pretty much what my research group would kind of focus on. In the late 1990s through the early 2000s, we would publish a series of papers in the New England Journal, kind of summarized here, saying that all sorts of biomarkers of inflammation beyond C-reactive proteins, serum amyloid A, which is also an contraxin, ICAM1, an adhesion molecule, interleukin-6 itself, is the data on the left. They all interact with lipids to produce high risk. The data on the right were important because they showed that this was true not just in men, but also in women, but further, that you could predict vascular events by measuring high sensitivity CRP just as well as you could by measuring LDL cholesterol. But we understood at this point in time, you couldn't predict A from B. That's one of the most important lessons we have in the lipid world. You don't have any idea what your patient's inflammatory cascade is by measuring their lipids. And I would argue, and I will argue again later, I'm sure in the Q&A, none of us would treat hyperlipidemia without knowing the LDL cholesterol. None of us would have the chutzpah to treat blood pressure without knowing what the blood pressure is. Why are we possibly thinking we know what we're doing with inflammation without actually measuring it? We need to measure this because you can't really treat a patient or know what's wrong without measuring what's going on. In 1999, the actual assay was released, the high sensitivity CRP test. You see some of the early adverts for this. I like the one on the far left. You see sort of either this physician or the scientist looking through into the future at this burning heart, and you see the immune cells floating around over there. On the right-hand side is the canonical data that we published years ago saying that HSCRP levels less than 1 to 3, greater than 3 milligrams per liter represent lower, moderate, and higher risk in the context of usual Framingham type risk factors. We still say today, as we did back then, if your level is greater than 10, go ahead and repeat it to make sure you're not as part of the acute phase reactant. You'll be surprised how often it still comes back greater than 10. We have a huge cohort of patients who have very high HSCRP levels, 30, 40, 50. It's largely on a genetic basis. And I do want you to measure it a second time just to make sure you're not being fooled by the acute phase response. But many of these will turn out to be real, and they're very high risk. Some of you remember the original statin data. Again, this is 25 years ago. This comes from the CARE trial. These were our papers in 98 and 99 showing that pravastatin, a relatively modest statin in retrospect, was highly effective in the presence of inflammation as compared to the absence of inflammation. And a year later, we would show that when you gave, in this case, pravastatin, we show, and it was true of all statins, you actually lower CRP. So we learned very early on that statin therapy, the miracle drug of our era, is both a lipid lowering and anti-inflammatory intervention. In 2005, on the left, we would show in the Prove It trial, remember there was high dose, low dose statin, that the best outcomes were when both the LDL and the CRP came down. Aaron Bahula in the Improve It trial would show the same thing a decade later. And again, this is the whole concept of dual goals, this whole notion that our guideline folks still don't have their heads wrapped around, that if you only monitor the lipid part of this equation, you're not going to do the best thing for your patients. The Jupiter trial, you're well aware of. I want to give you a quick overview. We would start this trial in 2000. It ended in 2008. For those of you who are newer to the prevention world, you may not know that in 2000, when we started this trial, primary prevention guidelines were if your LDL was above 160, be really aggressive and bring it all the way down to 130. Well, that's where we were in 2000. So we said that makes no sense. We knew inflammation was at least as important as lipids. So we designed a clinical trial where nobody would receive a statin in primary prevention because the average LDL in Jupiter was only 104 back in the year 2000, when the guidelines said lower it all the way down to 130. And yet, by enrolling people with an elevated CRP, we delivered the largest relative risk reductions of any statin trial ever done. And again, I want to take you through this because we get pretty excited today about relative risk reductions of 10, 15%. Look at these data. It's a 44% reduction in the primary MACE endpoint, a 63% reduction in MACE, a 48% reduction in stroke, 46% reduction in any revascularization. And I would point out that Jupiter is the only primary prevention statin trial ever to show a statistically significant reduction in all-cause mortality. On the right-hand side, I show you that was true even when the only risk factor people had was a CRP greater than 2, irrespective of any other risk factor. This is important to think about because the guidelines, as you're well aware, would change after Jupiter to put far more people on statin therapy. But once again, our guideline writers failed to understand the underlying biologic principle of Jupiter, which is that you really ought to treat people who have an elevated CRP, irrespective of other risk factors, just like we would treat people with an elevated LDL cholesterol. But Jupiter was not a test of the inflammation hypothesis of atherosclerosis because obviously it's using a lipid-lowering drug that has additional anti-inflammatory properties. So the question was, how would we get to a true test of that hypothesis? So I show you here a biologic pathway for the second time. This once again is the same NLRP3 pathway I talked about earlier. This pathway is very important in innate immune function. We all have it in lots of innate cells that are very important for our survival. It can be activated by cholesterol crystals, by mitosis, by atheroprone flow, by many different stimuli. But again, this inflammasome, which is typically triggered by crystalline structures, foreign structures, the body says, aha, that's foreign. I'm going to go ahead and attack it. I'm going to attack it by activating the caspase system, which is going to convert pro-IL-1 beta to locally secreted IL-1 beta. IL-1 beta and IL-6, as a consequence of that, have many direct vascular effects. And as I said earlier, IL-6 itself will also push the liver to put out a series of acute phase reactants, some of which are very important. Plasminogen activator inhibitor type 1, Pi1, and fibrinogen are very involved in thrombosis. And CRP itself, the biomarker, also comes out of liver. Now, this hypothesis we had early on, the question was, could we intervene on it? I want you to look at the photomicrograph in the upper right, the black and white. You see a cholesterol crystal. That's not circulating cholesterol. That's crystalline cholesterol, the same stuff that the cardiologists shatter every day in the cath lab. And nestled up against it is an innate immune cell. That's the target we're after here. And the lower right-hand corner, it's a cover of Science a couple of years back. Again, you see the yellow crystalline structure. That's cholesterol crystal sitting inside that netosis-prone plaque. Anyway, we designed what you know as CANTOS, the canakinumab anti-inflammatory thrombosis outcome study, to test this fundamental hypothesis by using a drug that was not like a statin that lowered LDL, but a drug that only and highly specifically targeted that inflammasome activation by inhibiting, neutralizing interleukin-1 beta itself. This is a monoclonal antibody that directly targets IL-1 beta. The trial enrolled about 10,000 patients globally. We're now in secondary prevention, unlike Jupiter, which was primary prevention. Everybody has residual inflammatory risk, which is to say they're all on high-intensity statins. They're all getting very aggressive contemporary care, but the high-sensitivity CRP remains above that threshold of 2 milligrams per liter, so they have this residual inflammatory risk property. When we started this trial, to be honest with you, we weren't really sure what dose of canakinumab to give, so we gave 3 different doses. For your purposes, just consider it low, middle, and high against placebo. I want you to look in the lower left. The experimental part of this, if you like, on a global basis was quite elegant. We had dose-dependent reductions in high-sensitivity CRP, and by proxy, dose-dependent reductions in downstream interleukin-6 by giving greater doses of IL-1 inhibition. But no change in LDL, no change in HDL, no change in triglycerides. I could also show you other data. No change in blood pressure, no change in hemoglobin A1C. We did one thing and one thing only. We blocked interleukin-1 beta. And on the right-hand side, you see the data showing a 15% reduction in MACE and a 17% reduction in MACE plus that were highly statistically significant for the middle and high doses of canakinumab compared to placebo. Now, that's 2017, which is a very important year because that's also the exact same year that the Fourier trial and our Spire trial of bococizumab read out. So we had identical data for PCSK9 inhibition. I mean, virtually identical 15, 17% event reductions. But unlike the PCSK9 trials, CANTOS did this without changing ApoB or LDL cholesterol at all. We simply lowered CRP and lowered IL-6. And so this trial becomes very important for biologic reasons. Now, you can't give canakinumab for atherosclerosis, and that's not because the FDA did not want to approve the drug. It's not because of any safety issues that were raised that were particularly difficult. It's simply because the sponsor of that trial, Novartis, changed priorities of the drug because we made another very important observation in CANTOS. Those data are shown here. These are very large dose-dependent reductions in incident lung cancer, in particular non-small cell lung cancer. The reason for this is the same inflammasome activation that we're talking about in the vascular system occurs in the lungs when one smokes cigarettes or breathes in asbestos or other environmental toxins. The same inflammatory process occurs. But now you're seeing 50, 60, 70% reductions in incident lung cancer. So happy to talk about this another time, but there's an enormous development program going on now looking at IL-1 inhibitors as adjunctive therapy for lung cancer, which is where this whole field has gone. The question, though, becomes what can we do today? With funding from the NHLBI, we did a trial using low-dose methotrexate that was known as CERT, the Cardiovascular Inflammation Reduction Trial. That trial, however, did not lower events, even though methotrexate is the canonical drug used to treat rheumatoid arthritis. But we also learned that in atherosclerosis patients, low-dose methotrexate didn't lower IL-1, it didn't lower IL-6, it didn't lower CRP, so maybe we shouldn't be surprised that it didn't have any benefits. In fact, we see that trial as a nice neutral control for CANTOS, telling us, aha, if you're going to get this inflammatory benefit, you have to hit that central IL-1 to IL-6 pathway. So let me take you through where we can go today and where we're going tomorrow. So again, we're back to this inflammasome pathway for the third time, but now you see the numbers 1, 2, and 3. I've already done number 1. That's interleukin-1 inhibitors. I talked about canakinumab. There's several other IL-1 inhibitors out there. I now want to shift to number 2, colchicine, And then I'm going to come back to number 3, which is IL-6 inhibition. But colchicine is really quite important because colchicine is a drug that's been around for 60, 70 years as a pharmaceutical and has been around for millennia as an anti-inflammatory drug. From a biologic perspective, the drug is a microtubule polymerization inhibitor. So it actually affects neutrophil function and affects the polymerization of certain protein structures, one of which appears to be that central NLRP3 inflammasome. So indirectly, we're inhibiting this process and we're inhibiting neutrophil function. If you're interested in colchicine, there's been some very nice review articles written over the last year or two, and we have some coming out on our own. But the most important thing I want you to learn from this evening is simply this drug alters those microtubules and therefore interferes with neutrophil function, it interferes with neutrophil platelet interactions, it inhibits the inflammasome. And the question is, might it benefit our patients with atherosclerosis? So this question was asked by Stefan Neidorf and Peter Thompson some years ago in an open label, small clinical trial done in Australia. That was called low-dose colchicine, or LODOCO-1. It's an open label trial, but it had a hazard ratio of 0.33, and so very, very provocative among people who got low-dose colchicine. Low-dose colchicine, by the way, is 0.5 milligrams, 0.5 milligrams once a day. But this trial, it was open label. So the question becomes, what happens in a properly done, double-blind, placebo-controlled trial? Well, there's now been 2 of these, and they're the data I had in my earlier slide. Colcott on the left, which was roughly 5,000 patients with recent myocardial infarction in the last 30 days. And the second LODOCO trial, LODOCO-2, again, 5,500 stable coronary disease patients. But now look at these relative risk reductions. The hazard ratio is 0.77 for Colcott, that's a 23% risk reduction. And the hazard ratio of LODOCO-2, 0.69, that's a 31% relative risk reduction. Again, I want to point this out very clearly. Those risk reductions are larger, substantially larger than what you're getting by putting a patient on a PCSK9 inhibitor or ezetimibe or other common drugs. A couple of caveats, though. The first is that I would not use this drug among patients with chronic kidney disease. Colchicine is renally excreted, and I'll come back to some reasons why that could get them in trouble. But also, as you see in the yellow box in the lower right, there was no benefit in the setting of CKD. So that's just one thing you have to remember when you're doing this. This is the current meta-analysis of all the trials that are available to us today. So the first LODOCO study, LODOCO-2, Colcott, and another trial called COPS, which was a smaller trial. The bottom line is, again, a 25% risk reduction that's highly significant for an MI, stroke, and cardiovascular death, and an even larger reduction when we add in cardiovascular death. All-cause mortality is, in fact, neutral so far in the colchicine trials. Some people have said to me, well, Paul, I don't want to give a drug where all-cause mortality has not come down. And I have to remind them that we have no evidence of a reduction in all-cause mortality with ezetimibe, with bempedoic acid, or with the PCSK9 inhibitors. That's because it's very, very hard to show reductions in all-cause mortality when a data safety monitoring board stops a trial for non-fatal events. So I wouldn't hold that against any of these drugs. I think that's a non-argument from my perspective. However, and this is something you do need to know if you're going to think about using colchicine, the drug has some drug-drug interactions and a relatively narrow therapeutic index. So basically, you don't want to prescribe chronic low-dose colchicine to patients with seriously impaired renal or hepatic function. And you probably want to just hold the drug if they're going to get short-term use of some CYP3A4 inhibitors or P-glycoprotein inhibitors. The most common of these is fluconazole, clarithromycin, fluconazole, drugs like that. And ritonavir, if you're going to go on 5 days of Paxlovid, you probably ought to stop your colchicine for those 4 or 5 days. There's no real evidence this is a bad thing, but I think I'm just being very conservative and don't want that to happen to patients. Besides which, it's a chronic drug. But this is a real problem for you. For those of you who have thought about colchicine, you probably noticed that the dose you have available in the United States is 0.6 milligrams in an oral tablet formulation. All these trials use 0.5. And the question is, does that matter? It actually does. That 20% difference in dose on a chronic basis is a substantially increased dose. On the left, you see some modeled PK/PD data for colchicine, 0.5 milligrams daily. And Those with normal renal function, everyone's fine. And then you can see as people start to develop 30, 50, 70% decrements in renal function, it's pretty rare until renal function is pretty bad to exceed the safe upper limit. But on the right-hand side at 0.6, even people with very mild impairment of kidney function can get in trouble. And I show you here in the red box the data I'm talking about. So one thing we need to do is see if we can't get a 0.5 milligram tablet labeled in the United States, specifically for atherosclerosis. And for reasons I won't talk about this evening, I'm optimistic something like that might happen in the relatively near future. In any event, where are we going? Well, CANTOS was defined and pre-specified to also ask some questions about how this process might work. And just focus on the right-hand side that we showed that most of the benefit of CANTOS is when IL-6 levels came down. Well, that's not that big a surprise. On the left is our data from 23 years ago. IL-6 is a powerful predictor of future vascular events. The right-hand side is the meta-analysis for IL-6 showing this is true over and over. We performed a clinical trial that was called Rescue that was published in 2021 in The Lancet with a new novel IL-6 monoclonal antibody targeting atherosclerosis, or being developed to target atherosclerosis. And the point was that we got 75, 80, 90% reductions in hs-CRP, which were much larger than what we got in CANTOS. CANTOS only delivered about 35 to 40% reductions. So by directly targeting IL-6, we could get far greater inhibition. And with that drug, we went ahead and designed a clinical trial called ZEUS. This is the ziltivekimab cardiovascular outcome study that's ongoing on a global basis. Ultimately, it's going to randomize over 6,000 patients with atherosclerotic cardiovascular disease and residual inflammatory risk, that is to say a CRP greater than 2, but who also have stage 3 or 4 chronic kidney disease. So why are we doing that? Well, first, as I just said, these are patients I can't give colchicine to. But equally important, this is a very tough group of patients to treat because their atherosclerotic risks are very high. As you're well aware, they're much more likely to succumb to a cardiovascular event than they are to renal failure, ultimately. And it's a population that, even though we do use statins, the relative efficacy of lipid lowering is smaller and smaller and probably non-existent in the setting of dialysis. So in any event, we are randomizing these patients to IL-6 inhibition with ziltivekimab plus aggressive usual care compared to placebo. I co-chair this trial with Vlado Perkovic, who's a nephrologist, because we really have two different endpoints. The major adverse cardiovascular events is the primary endpoint, but progression of renal disease is a secondary endpoint. And this trial is about halfway enrolled on a global basis today. So we'll get some data about this within, hopefully, maybe 2 or 3 years. What about heart failure, in particular, heart failure with preserved ejection fraction? These are data from my colleague Brendan Everett, coming again out of CANTOS, showing that CRP and IL-6 predict incident heart failure, showing that we did get a reduction in hospitalization for heart failure with canakinumab, and again, that these benefits were largest among those who got the largest risk reductions. We also have data for acute coronary ischemia in this setting, 2 trials in non-STEMI on the left, STEMI on the right, done by Lars Gullestad and his collaborators. These are phase 2 smaller studies telling us that it's safe to give an IL-6 inhibitor in this setting, and that we can get reductions in CRP, we can get reductions in troponin, we may get reductions in myocardial salvage. And so again, we have ideas here about where this might go. And I'm proud to say that working with Novo Nordisk, who picked up this drug ziltivekimab a year or 2 ago, they've now launched 3 major multinational clinical trials. I told you about ZEUS already, whether or not IL-6 inhibition will lower cardiovascular event rates in chronic kidney disease. The second trial, which goes under the rubric of Hermes, is whether or not IL-6 inhibition with this with ziltivekimab will improve outcomes among folks with HFpEF. And a third trial just now being organized that's going to go under the name of Artemis is going to be an acute myocardial infarction, acute coronary ischemia trial. So it's very exciting for us because this whole inflammation biology piece will be done on top of lipid lowering in many different vascular settings. So let me try to wrap this up before we take the Q&A from you. The first is I want to show you the canonical lipid lowering line that we as lipidologists have always sort of known. This is the percent reduction LDL on the x-axis plotted against the relative risk reductions on the y-axis. And you see in the orange diamonds all of the lipid lowering trials. But on the far left, the three red diamonds, that's Cantos, Colcott, Lodoco 2, 0% reduction in LDL, large relative risk reduction. Second thing to take home is inflammatory risk, but I didn't tell you how common it is. If you're measuring hsCRP in every patient who comes in, just like you might measure LDL cholesterol, you'd find that there are 2 to 3 patients with residual inflammatory risk for every 1 patient with residual cholesterol risk. And I think that's a major problem. Again, I want to repeat this. None of us would treat lipids without measuring LDL. None of us would treat blood pressure without measuring blood pressure. You've got to measure CRP in your patients if you're going to take on this new biology. I'm a preventive cardiologist, so I'm a major believer in diet, exercise, and smoking health pyramid, where you see at the bottom exercise equipment and fish and whole grains. A little bit of alcohol is always a nice thing to go. And then as you get to the top is when there's very few red meat, etc. This has been proven over and over. I'll point out to you again that in the prevention world, remember the Predimed data for a randomized trial of Mediterranean diet and mixed nuts and or Mediterranean diet and extra virgin olive oil. This is event reduction by simply changing the content of calories. I love the quote from Annette Christ and Ika Lotz. The Western diet appears to be mistakenly recognized by the immune system as a threat to the organism. You can think about that a little bit. And finally, we all recently saw the data from the CLEAR Outcomes trial with bempedoic acid. I have to say I was terrifically flattered by the way that the bempedoic acid investigators chose to present their data in the New England Journal of Medicine, because right before showing the outcome data, which you see on the left, they showed the panels you see on the right. And they were plotting the LDL lowering data and the CRP lowering data side by side, because again, I think the world has finally come to recognize that drugs that do both of these things are better than drugs that do just one. And that's really where we kind of sit. So to bring this to a close and then take some questions from you, I want to repeat, it's not an either or situation. Lipid lowering and inflammation inhibition are not in conflict. They're synergistic with each other. And in the future, those of us in the vascular biology lipid community strongly believe that the combined use of aggressive LDL lowering and aggressive inflammation inhibiting therapies is going to become standard of care for almost all of our atherosclerosis patients. And you can do that today by using inexpensive colchicine, at least among the patients who have preserved kidney function. Further, in addition to increasing the use of targeted anti-inflammatory therapies for atherosclerosis, the concepts we've been talking about tonight surrounding the inflammation hypothesis of atherosclerosis strongly support ongoing ACC-AHA prevention efforts directed at diet, at weight loss, at exercise, and smoking cessation, all of which lower vascular inflammation and all of which lower cardiovascular event rates. So I'm going to close with a slide from a review article that we hope will be coming out in JACC pretty soon about managing residual inflammatory risk and residual cholesterol risk in patients with stable coronary disease. On the left-hand side, I've assumed I'm going to give these patients a high-intensity statin, and then I've assumed that you're going to measure both an LDL and a CRP. And then I've divided people up into 3 groups you've seen. Those with residual cholesterol risk, well, if the LDL is above, say, 70, but the CRP is low, you'd consider a second lipid-lowering drug, and that'd be perfectly fine. On the right-hand side of that thing, you see, well, the LDL is low and the CRP is high. That's residual inflammatory risk, and you might consider adding a lipid, an inflammation-lowering drug, perhaps colchicine, perhaps others there. And of course, in the intermediate group, if the LDL is above 70 and the CRP is above 2, that's a dual pathways. You might actually add both, say, a PCSK9 inhibitor and perhaps colchicine. And that, I think, is the way we're going to think about this. And on the far right-hand side, once again, just to make you have a thought experiment, you'll notice that the 2 inexpensive trials, the inexpensive drugs, colchicine, are actually delivering more risk reduction than the expensive drugs. That doesn't mean I don't use the expensive drugs. Of course I do. But it also means I think twice about this and ask my patients to think about taking the anti-inflammatory when it's clinically appropriate. And for me, that's when the GFR is normal and they don't have any evidence of significant liver disease. So I'm going to stop there and figure out how to come back to all of you. There we go. And Guy, it's been an absolute pleasure, but I'd be more than happy to take questions. And next time we'll see you in person.
Yeah, thank you, very much, Paul. That was very stimulating talk. I don't think it was controversial. I think it was really eye-opening. And for those of you who had their whistles wet tonight or appetite for inflammation touched, Dr. Richter will be appearing live at the NLA National Scientific Meeting in Atlanta, June 1st through June 4th. So, thank you for that, Paul. There are a few questions I'll ask you. Back in the day, there was a group out of Italy, I think his name was Biasucci, and they were looking at inflammation post-stent or post-CABG in those patients that had ongoing inflammation, post-revascularization, were at high risk for future events, restenosis and cardiovascular events. So is that research still being, carried out with us over here in different forms?
Sure, so your memory is very good. So Luigi Biasucci is a good friend. The senior leader of that lab was Attilio Mazzari, who, among other things in life, was the Pope's.
Oops. You guys, please mute your mics. Appreciate it.
There you go. I think we're back. So Attilio Mazzari, who passed away, unfortunately, a few years ago, right before COVID, he had been the Pope's cardiologist and actually had the honor of giving the Attilio Mazzari lecture in Trieste before he passed. And he was a wonderful man. But yes, so acute coronary ischemia, that was the controversy, because people had said, look, CRP, serum amyloid A, they go up after acute ischemia. And that's true. But the twist in the whole story was to figure out that they actually went up in advance. Now, that being said, all the logic behind doing these acute coronary ischemia trials comes from his original data. It just took us 30 years to figure out that we could target this and it would be safe. So it is still ongoing, and it's underlying this idea that maybe in the cath lab, when we open an artery, and maybe in acute, a STEMI situation, we should probably think about anti-inflammatory therapy, and those trials are being designed.
Terrific. All right, here's a question for colchicine. Do you adjust the statin dose when you use chronic colchicine? Is there any safety monitoring you need to do? And should these patients be kept on the colchicine dose, quote, for life?
Okay, so that's a very astute question. So I suspect that's from someone who tried to prescribe colchicine and got a silly note from the pharmacy saying, watch out for this. This is a really unfortunate problem. The pharmacists, I hope there's pharmacists on this call, they need to fix this fallacy. So there is no evidence whatsoever in the two major clinical trials where everyone's on a statin. When they got 0.5 milligrams, there's no myopathy, there's no problems whatsoever. So where's this coming from? This is unfortunate. This is one of these things where pharmacy things from 30, 40 years ago have never been updated. If you give colchicine at a high dose to treat acute gout, now we're talking 1.5 to 2.4 milligrams a day. That's 4 times the dose we're talking about here. And you happen to be on fluconazole, or you have liver failure, or you have renal failure. Yes, you will get in trouble with your statin because the statins are also metabolized that way. So it's about 25 case reports worldwide in the literature. We reviewed these for the FDA to point out that this is a complete fallacy. But unfortunately, even at the Brigham today, when I prescribe colchicine, I get a little automatic notification from someone who's not thinking saying, careful with your statin. But the clinical trials done, 10,000 patients, 50,000 person years, there wasn't a single case of this, and they're taking high intensity statins, but they don't have liver disease, they don't have kidney disease, et cetera. So we have to fix that problem. But no, I don't change the statin dose, and I try to give 0.5 if I can get it. And we need to get a 0.5 for the US market.
Okay, great. I'll read this question verbatim. So someone has been bothered by the Colcott and Lodoco studies that they did not measure high sensitivity CRP or do a heterogeneity effect analysis by CRP lowering levels. They did a treat all approach. Do you know why? Do you use high sensitivity C-reactive protein in your decision making to start colchicine?
Sure. So there is other data available that was available before those trials were done that shows that colchicine does lower CRP. So that's an easy part of the answer. They didn't do it in their trials for a very simple reason. They didn't have any pharmaceutical backing. These trials were done on with virtually no funding whatsoever. So they don't have the bells and whistles of all the clinical trials that you're used to, but they do have the only two things that really matter. They're large, they're randomized, and they're double blind. Now, I do measure CRP to decide who I'm going to give colchicine to, because when you think about a secondary prevention trial, which both Colcott and Lipid were already on a statin, they're almost all going to have a high CRP. So I would guess in those trials, 75, 80% probably had levels greater than 2. And again, my general feeling is I don't want to diminish lipid lowering. I want to use that aggressively when that's the problem. So if CRP is the problem, I'm probably going to go down that route.
Okay, great. Since CRP is influenced by multiple factors, would the use of uric acid be a more accurate measurement of inflammation, especially with the potential to use colchicine as secondary medical therapy?
No. Colchicine is at much higher doses, 3 to 4 times higher doses, is obviously used to treat gout. But for reasons I don't want to go through right now, the whole biologic system here is quite different. There is some hypotheses that uric acid crystals might deposit outside the joints, but also in the coronaries, but it's really early data, and we don't yet have any evidence that lowering serum uric acid actually alters cardiovascular event rates. And of course, we have overwhelming evidence that lowering LDL and lowering CRP does. So no, we're not going to go towards that direction. And again, just be careful here, because the dose of colchicine for gout is 4 times higher, and it's only given for 2 or 3 days. We're talking here now chronic, lifelong therapy. So again, be very careful about the dose.
Okay, great. Any thoughts for treating the patients that have, inflammatory disease, whether it's rheumatoid arthritis or psoriasis, where the CRPs are coming back greater than 10? How do you risk stratify that group?
Yeah, so I love that question. Thank you, guys. So there's a wonderful paper in the Lancet that when I have a longer version of this talk, I often talk about, which shows that there are 26 different disorders that were ranked as autoinflammatory diseases. So we're talking psoriasis, inflammatory bowel disease, Crohn's, Addison's disease, ankylosing spondylitis. Every single one of them is associated with elevated cardiovascular risk. So it's not a false positive. It's an understanding of biology. These disorders of systemic inflammation that happen to affect, say, the small bowel or the colon or the skin also are affecting the vascular endothelium. So we don't look at these as false positive at all. We look at them as evidence that inflammation on a chronic basis is problematic. And that's what the real issue here is.
Great. And generally, here's another question for you. When HSCRP first came out, I even remember United Healthcare wasn't paying for it, and patients were getting, balanced billed. So pretty much is HSCRP an accepted and paid for laboratory test today?
Yes, that's like a problem from 20 years ago. Don't worry. Yes. Anybody getting a reasonable insurance program is going to have it. By the way, it's really inexpensive, and we're talking, $7 or $8. It's no more expensive than getting a lipid panel. So, yeah, that's a problem of the past. I do wish our insurance companies, frankly, I wish our guideline writers would get with the biology, but yeah, that's not an issue. What is an issue, of course, and I see it in the chat here, that colchicine in the United States is more expensive than colchicine in the rest of the world. That has to do with some complicated FDA issues a couple of years ago about rebranding generic drugs. But even at the U.S. price, if you think about it, it's still, to be honest with you, far more cost effective than, say, a PCSK9 inhibitor, both on a cost basis and because the relative risk reductions are larger. Again, I want to be careful. It's not like I don't give PCSK9 inhibitors. Of course I do. But I'm trying to figure out what's my individual patient in front of me's problem. So if their LDL's still high, again, despite their high intensity statin, and the CRP is low, sure, I'll write for a PCSK9 inhibitor. But if the CRP is very high and the LDL's 65 or 70, I mean, the incremental benefit of dropping the LDL further, it's real. There's a benefit, but it's a pretty small benefit compared to the inflammation we haven't tapped yet. So even at the higher price of colchicine in the US, it's still very, very cost effective for the system writ large.
Okay. Changing focus, lipoprotein A is known to be pro-inflammatory. Would you consider the use of colchicine in our patients walking around with high elevated LPAs and increased risk for cardiovascular events? in the setting of elevated CRP or in the setting of normal CRP?
Well, it's an excellent question from a biologic perspective. I have to admit that when I am in clinic, I tend to be a little more conservative. So I'm waiting to find out whether the LPA lowering trials actually deliver benefit. We'll know within a few years. And I pretty much am limiting my colchicine use to folks who have an elevated CRP. I am concerned about people with LPA. And again, just to be clear, we measure it once, right? There's no reason to measure it twice. It's a genetic risk factor for all practical purposes. And I really hope the LPA lowering trials show some benefit, but it's obviously right now highly controversial. So we have to wait and see.
Yeah. I noticed one of the trials coming out in the future with your monoclonal antibody had an LPA arm in it. I don't know if that was Artemis that you just talked about tonight, or the Hermes.
Well, there's no LPA arm in it. We are measuring a variety of biomarkers along the way, but there's no LPA enrollment criterion. It's simply we're trying to figure out what else are these drugs doing. And the reason for that is because what you probably saw, which is correct, is that in the ziltivekimab phase 2 data that's published, in addition to lowering CRP 80-90%, we got a series of other benefits. We lowered fibrinogen, we lowered SAA, we lowered SPLA2. We also lowered Lp(a). This is probably the part you're remembering, which is very astute of you. It's a modest reduction, 25-30%, but there's a reason for it. And that's because the ApoA genetic loci is actually under the IL-6 control. And so it's been known for a long time that you can't make ApoA without IL-6, and therefore you can't make Lp(a). But it's not anywhere near the 70-80% reductions that you'll see with some of the novel LPA lowering drugs. But again, it's probably a good thing in the general sense. And so we'll see.
Okay, and I think we have one last question, which one cardiologist in a group of 30 is using colchicine, and can't believe the rest of the group is reluctant. So any thoughts on how to get 29 believers to join the one disciple?
So I'm going to be very careful what I say here. Look, anybody taking time out on an evening to come for a Neela Nights event is already a pretty advanced cardiologist, general internist, pharmacist, et cetera, because you're self-defining yourself as individuals who are interested in figuring out what's new, what's different, how can we make care better for our patients. I am quite convinced of the following. If low-dose colchicine was 10 times more expensive and 1/3 as effective, but under patent, we'd all be marketed up the wazoo to use this drug every day. And we'd probably be using it quite widely. And I think that's a fairly sad commentary on how medicine actually works. Because again, we're all using very expensive agents that are less effective on a daily basis. Not that that's bad, I do it too. But the question is, why aren't we also doing this? And again, I want to point out, this is not a competition with lipid lowering. This is an adjunct. It's the part of the piece we haven't hit yet. So I'd say take a look at the data, go back and do it, do journal clubs, read the papers. As I say, I think we have a review article coming out this pretty soon. Think about it.
That's great. Well, Paul, I want to thank you for taking the time out tonight and giving us a peek in the world of inflammation, past, present, and future. I think it's an eye-opening thought process for all of us, and we look forward to seeing you live in Atlanta. So again, for those of you on the call, Paul will be speaking. There's going to be a vascular biology section, including inflammation, and join us for NLA National Scientific Meetings in Atlanta. Paul, thank you again. Really appreciate you taking the time for us this evening.
Guy, my thanks to you, and I'm going to go catch the second half of the Celtics game.
All right, go Celts. Take
Have a good
care.
evening. Thanks.
Bye-bye. Thank you.